My name is Dr. Patrick McGahan, and I'm an orthopedic surgeon specializing in sports medicine and knee surgery. Today, I'd like to share with you some tips for the physical examination of the knee. In this scenario, I'm going to be dealing primarily with chronic knee pain. However, I would first like to say something about acute knee pain. When a patient comes in with an injury to the knee, such as from skiing, cycling, soccer, or basketball, radiographs are necessary. Radiographs first will rule out a fracture. If a patient has persistent pain with an acute injury and inability to bear weight, an urgent MRI and orthopedic referral is necessary. In this scenario, I'm going to be dealing primarily with patients with chronic knee pain. Even in that scenario, radiographs should be the first step. When radiographs are obtained, if a patient has evidence of arthritis, then I would recommend physical therapy, cortisone injection, and referral to an orthopedic surgeon. Today I'm going to be referring to this handout, which will also be in the notes. This is a nice flow chart for the most common orthopedic conditions that result in chronic knee pain. The first part of the flow chart shows that radiographs should be obtained. This can easily diagnose arthritis, and the appropriate treatment recommendations can be made. For patients with chronic knee pain who have normal radiographs, the next step is an appropriate history and physical examination. With an appropriate history and physical examination, an examiner can diagnose 90% of common knee conditions and treat them appropriately. This is my patient here today, and I'll take you through a common physical examination. When I first see a patient, I ask them where their knee pain is. Commonly, patients will describe anterior knee pain, deep knee pain, catching, locking, feelings of instability. So the history is the first part of the physical examination. When I start my physical examination, I like to start with a single leg squat. A single leg squat can tell you a lot about a patient's condition. If a patient has pain with single leg squat, that can indicate a meniscus tear, arthritis, or patellofemoral syndrome. If a patient has pain with Thessaly's maneuver, that can indicate a meniscus tear. When a patient has pain with the Thessaly's maneuver, which I'll show briefly, a patient will often indicate pain along the joint line. This is important to distinguish because a patient with patellofemoral arthritis or other conditions can also have pain with Thessaly's, but the pain will typically be more anterior rather than along the joint line. So when I walk into the room, I ask the patient to stand up, stand on a single leg, and do a single leg squat. Pain with this maneuver can indicate patellofemoral arthritis, patellar tendonitis, or quadriceps tendonitis. It also can indicate a meniscus tear. In order to differentiate a meniscus tear, I ask a patient to do a single leg squat and then twist. This is called the Thessaly's maneuver. If a patient has pain, particularly with the twisting, this is a positive Thessaly's test and has a very high sensitivity for a meniscus tear. After I do this exam, I ask the patient to lay down. Actually, first, if you can swing your legs this way. As you can see, I've marked some drawings on the knee. When I'm performing a physical examination, this is the picture that I have in my mind of a patient's anatomy. You can see here I've outlined the patella, the patellar tendon, the tibial tubercle, Gerdy's tubercle where the IT band inserts, the medial femoral condyle, the medial tibial plateau, and the medial joint line where the meniscus is. The first thing I do is I palpate the patient. I press along the patellar tendon. Pain along the patellar tendon can indicate patellar tendonitis. Above the patella, I palpate along the quadriceps tendon. Pain along the quadriceps tendon can indicate quadriceps tendonitis. Next, I palpate along the joint line. Pain along the joint line can indicate a meniscus tear. To the outside of the knee, you can see the IT band. Pain along the IT band can indicate IT band tendonitis. Next, I have the patient gently flex and extend the knee. What I'm looking for here is the way the patella tracks. If the patella tracks to the outside, that can indicate patellar maltracking. Please extend your knee again. I watch as the patella glides. He has very good tracking where the patella glides straight up and down the knee. However, patients with patellofemoral syndrome and patellar maltracking will have their kneecap pulled to the outside. This is called lateral patellar tracking, lateral tilt, and can sometimes be manifested as a positive J sign where the patella comes up and settles to the outside. Once again, straighten out. The other aspect of the examination is I put my hand over the kneecap while the patient flexes and extends the knee. I'm feeling for any crepitus or popping. Crepitus can indicate patellofemoral arthritis. Popping can indicate some element of patellar instability. Following this, I will have the patient lay down. Okay. And at this point, I'll perform a physical examination of the knee. I will first check range of motion. Following this, I'll do a ligamentous exam. I will bring the knee first to about 30 degrees of flexion and then apply a gentle valgus force. This valgus force is stressing the MCL. Pain or instability on this exam can indicate an MCL injury. Next, I'll do the same thing but apply a varus force. Pain or instability at this point can indicate an injury on the outside of the knee to the lateral collateral ligaments. Following this, I'll ask the patient to relax, bring the knee to 30 degrees, and then provide a gentle anterior force to the tibia. This is called the Lockman's exam. Laxity with this exam can indicate an ACL tear. Following this, I'll bring the knee up to 90 degrees, and I'll gently sit on the patient's foot to control it. I'll put my fingers on the tibial condyles, and I'll gently press posteriorly. This is called the posterior drawer test. Instability or pain with this exam can indicate an injury to the PCL. Again, I want to draw your attention to the medial joint line. These pictures I've drawn are what is in my mind's eye when I'm examining a patient. I'm feeling the medial femoral condyle, which can be painful with an MCL injury or with arthritis. I'm pressing on the joint line where the meniscus is. This can also be painful with arthritis or a meniscus injury. And I'm pressing on the medial tibial plateau. Similarly, on the outside of the knee, I have the same landmarks in my mind. This is the IT band where it runs over the lateral femoral condyle. In patients with IT band friction syndrome, they will have pain over the lateral femoral condyle. This line indicates the meniscus, which is situated between the lateral femoral condyle and the lateral tibial plateau. Pain over the meniscus can indicate a meniscus injury. Finally, I have indicated Gerdy's tubercle, which is the insertion point on the lateral tibial plateau for the IT band. Pain over this area can also indicate IT band tendinitis. All right, can you please stand up? So what I've done with that short examination is show you how you can diagnose the most common orthopedic injuries. The first is arthritis, and as I explained earlier, that will often be clearly indicated on the x-ray that's obtained. Following that, the most common diagnoses are meniscus tear, patellofemoral syndrome and patellar maltracking, patellofemoral arthritis, patellar tendinitis, quadriceps tendinitis, an MCL sprain, an ACL sprain, and IT band tendinitis. So what I'd like to do is take you back through that and review what some of these positive findings may look like. So again, as I come in the patient's room, I like to ask them first to stand up and do a single leg squat. Can you please do a squat? If the patient has pain on this maneuver, I'm thinking about patellofemoral arthritis, patellofemoral syndrome, patellar maltracking, or a meniscus tear. In order to distinguish a meniscus tear from those other diagnoses, I will first ask the patient to squat and then twist, which is the Thessaly's examination. If they have pain with the twisting, then I'm immediately thinking about a meniscus tear. Next, I'm going to have the patient sit down and face me here. And again, I'm going to have the patient gently flex and extend their knee. Okay? At this point, what I'm looking for is the patella. If a patient has lateral patellar tracking, lateral tilt, and a positive J sign, then what I'm thinking about is patellar maltracking and patellofemoral syndrome. However, patellofemoral arthritis will have very similar symptoms. In order to differentiate patellofemoral arthritis from patellofemoral syndrome, I'll place my hand on the patella and ask the patient to gently extend their knee. If there's crepitus, then this indicates patellofemoral arthritis or a cartilage lesion of the patella. If there's no patellofemoral crepitus, then my diagnosis is leaning more towards patellofemoral syndrome or patellar maltracking. Next, I'll have the patient lay down. First, I will palpate the various landmarks which can help in the diagnosis. Pain along the patellar tendon would indicate patellar tendonitis. Pain along the quadriceps tendon will indicate quadriceps tendonitis. One diagnosis I haven't discussed is pain along the medial tibial plateau could indicate either pes anserinus bursitis, which is inflammation of the hamstrings tendons, or in rare cases, a stress fracture of the medial tibial plateau. Next, I will palpate along the outside of the knee, along the IT band. Pain which is over the lateral femoral condyle can indicate IT band tendonitis. As previously explained, I'll palpate along the lateral joint line, which can indicate a lateral meniscus tear. I will also palpate along the medial joint line, which could indicate a medial meniscus tear. Next, I will bring the patient out to full extension and gently test their range of motion. Following that, I bring the knee to 30 degrees to test for first an MCL injury, next an LCL injury, and then following that, an ACL injury with a Lockman's exam at 30 degrees. To finish the exam, I will bring them up to 90 degrees and apply a gentle posterior directed force for our posterior drawer test, which can indicate a PCL tear. So in this short examination, you can diagnose approximately 90% of knee conditions. I have spoken a little bit about the history, the physical examination, and the specific findings. With efficiency, this can all be done within 2 minutes, and I'll briefly review. I have the patient come in the office, they do a single leg squat. Following that, I do the Thessaly's test. Next, I have them sit on the table. I check for patellar maltracking and then patellofemoral crepitus. Following that, I palpate the patellar tendon, the quadriceps tendon, the medial joint line, the lateral joint line, the medial tibial plateau, and the IT band and lateral femoral condyle. After I finish that, I check their range of motion and stress the MCL, LCL, ACL, and the posterior drawer test for the PCL. With that, that is our conclusion of the physical examination of the knee, and associated with this video will be a handout which can help diagnose the most common knee conditions. Thank you.